Good evening, and thank you for joining us tonight for our webinar, Guide to Managing Inflammatory Bowel Disease, in partnership with St George Hospital. My name is Christina, and I'm a CPD Program Officer with the Central and Eastern Sydney PHN. Before we begin this evening, I'd like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and I pay my respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander people joining us this evening. Today's session will be recorded and will be available on our YouTube channel in the coming days. I'd like to encourage you to use the Q&A function at the bottom of your screen to submit your questions for the speaker, which will be addressed towards the end of the session this evening. At the end of the webinar, the evaluation survey link will pop up on your screens in your web browser, and we appreciate the feedback if you could complete that for us. It helps us plan our sessions, but also make sure that we target the topics that you're after as well. Certificates of attendance will be issued following. I'd like to now introduce our GP facilitator this evening, Dr. Martina Gleeson, as well as Kylie Turner, who's the Chronic Kidney Disease CNC from St George Hospital. Over to you.
Thanks, Christina. I'd just like to introduce our speaker tonight, Dr. Paven, Gastroenterologist from St George Medicine and Cancer Services Department of Gastroenterology. Dr. Paven completed his medical degree at the University of New South Wales, Sydney, graduating with honours in 2001 before undertaking postgraduate physician training in gastroenterology and hepatology at Royal Prince Alfred Hospital. He obtained his specialist qualifications in 2008 and has served our local area as a consultant gastroenterologist since 2011. Dr. Paven has been the Director of Physician Training at both Royal Prince Alfred Hospital and St George Hospital, and is a senior member of the National Examining Panel for the Royal Australian College of Physicians. He is a conjoint senior lecturer of medicine for the University of New South Wales. He is a senior staff specialist at St George Hospital with admitting rights at both St George public and private hospitals. Over to you, Gok.
Thank you, Kylie. Thank you, Martina, and thank you, Christina, and all of the PHN team for inviting me. Now, let me share my screen. What's happened here? 1 second. Hopefully, you are all seeing the slide in the proper view and not presenter. Kylie, Martina, or Christina, is it in the
correct view?
Beautiful, beautiful. I just didn't want it in the presenter view. So look, I usually try and make these interactive, but clearly that's going to be difficult in a webinar setting. But Martina has kindly agreed to take some questions even during the talk, and if it's reasonable to answer them as we're going, I'm happy to answer them as we're going. And I will. I think the richest part of these sessions is the discussion part and the Q&A part. So I'm going to try very hard to finish in 45 minutes so that I allow at least 15 minutes for your kind of questions and things you want to ask me. And I've tailored the talk so that if we're running out of time, I'm going to try and protect the question time at the cost of other things, because I think that's the really important part. And also try and protect the case-based stuff, because again, I think that's the important part of sessions like this. So look, let's get started. So I always start with a case. We should start with one case, and then I've got a few cases towards the end to discuss, but I thought it's really important to discuss what I think are the key things and the key aspects and the key role that GP can play in IBD management. And when I thought about this, I thought I would talk about the principles, the general principles of management, so you get an idea of our thought process when we're trying to manage IBD. And I'll again relate that to how you can contribute. Vaccinations and pre-immunosuppression screening is a massive part of IBD management and not always done well. And again, I think primary care has a critical role in that. Thirdly, fertility and pregnancy, it can be a very difficult issue, an emotive issue, and sometimes there's a lot of misinformation around management, medications, what's important, what's not. So we'll cover that. And then medications with perhaps a focus on the newer drugs. As you probably know, there's like been a plethora of almost an explosion of medications available, and I don't call them biologics anymore. We used to call them biologics, but we should really call them advanced therapies, because the small molecule oral drugs, which have just come on, are really kind of in that class, but actually aren't biologics. They're advanced therapies. And then, as I said, lots of time for questions. So, the learning outcomes, I want you to understand the principles of IBD management. I want you to have some understanding of the barriers to adherence, some understanding of the role of vaccinations and pre-immunosuppression screening and why that's important, some understanding of the management of IBD in pregnancy. And as I said, I don't need you to know all the ins and outs of the drugs, but a basic understanding of the medications with a focus on the new ones. So let's start. This is a guy I've only just met in the last couple of years, actually. A lovely man, an electrician and a local. So some of you, or one of you in the audience may well be his GP. When I met him, he just had a new baby. He's very engaged, lovely wife, was a psychologist, and he'd actually had ulcerative colitis. I met him around 2022, and he'd had it for about 6 years, initially on Mesavant, not always adherent to treatment, and unfortunately prednisone dependent for a period of time. And he had a history of anxiety and depression, and as you all know, that prednisone makes, or all steroids make, that worse. And certainly he was in a bit of a state when I met him. So just before I'd met him, he'd had a pretty bad flare, 5 to 6 times a day with blood and mucus, urgency and tenesmus meaning the feeling of incomplete evacuation, unable to work. And weight loss is one of the things I want, and you all do this already, but in ulcerative colitis, it's a big red flag. It means they've got very active disease, which needs more management than they're getting. And again, there are a couple of other red flags on the bloods. Hemoglobin's low, albumin's low, CRP, and this is an important point. Sometimes in severe IBD, the CRP alone can be misleading. Have a look at the CRP versus the fecal calprotectin. The CRP alone, and it's a really important point with this slide, can be very, very misleading. The key things I want you to look at: weight loss, severe hyperalbuminemia, anemia, and a calprotectin of 4,000. And the lab sets a limit of 50 as normal for Calpro. We use 100 as the normal cutoff, and in IBD, it should be 100. So he had a colonoscopy, and this is his colonoscopy. And again, this shows moderate to severe colitis, and at least from the rectum to the descending colon. And sometimes people use the words, only left-sided colitis, but actually ulcerative, the phenotype of location doesn't affect severity. So we should move away from kind of trivializing left-sided disease, because it can be equally severe. And this guy, Mayo 3 is the highest score you can have, and he's at least moderate to severe colitis. One of the other things that's important, and an important part of colonoscopy in someone who's already immunosuppressed, is to make sure they don't have CMV. So one of the things we look for and always test for is send off the biopsies for both DNA analysis, but also the presence or absence of CMV inclusion bodies. So look, he was admitted to hospital, received IV hydrocortisone on top of mesalazine, but he clearly wasn't responding to that. And at 72 hours, if they're not responding, we escalate and reach for what we term as rescue therapy or salvage therapy. And the two key salvage therapies for ulcerative colitis over the last decade, 2 decades, has been either cyclosporin infusion, given as a continuous infusion, or infliximab, which is a one-off dose. And notice the standard dose is 5 milligrams per kilogram, but when they're sick in hospital, we usually give them 10 milligrams per kilogram after pre-immunosuppression screening, which we'll talk about briefly, in a minute anyway, and you'll get a sense of that. And when I reach for infliximab, I always reach for colorectal review, even though they might not be required in the days of biologics now. We rarely need colectomy, but I think it's much better to have joint management from the time you reach for salvage therapy, so that the patients have both teams looking after them, and perhaps most importantly, that a young patient has time to process and understand the concept of a total colectomy and what that might mean to their life and lifestyle. If you come in at day 7 after they've failed everything and say, listen, everything's failed, I think you need to see a surgeon, and they meet the surgeon for the first time, most young people are going to say, there is no way I'm having my bowel taken out. And I'm sure you all as GPs can understand that. And he clearly needed other things as well. So I added azathioprine to his regime. So look, he had some initial response, and this sometimes happens in ulcerative colitis and Crohn's. He got a bit better, but this is some of the effect of prednisone, isn't it? And as soon as his prednisone started to wean, he went downhill again. And just to highlight the degree of weight loss, he's gone from 50 to 65 with an exacerbation in his underlying chronic mental health. We now have the ability, which we didn't a decade ago, to actually have therapeutic drug monitoring with most of our drugs. So we can check levels of azathioprine in the blood, and that's with a test called 6-TGN and 6-MMP. 6-TGN is the active metabolite of azathioprine, and we have a target level, which I won't bore you with. 6-MMP is thought to relate to some of the side effects like nausea, abnormal LFTs, arthralgia, fatigue, and hence we can kind of dose titrate a little bit. But he was already dose optimized. He had full dose azathioprine already, and we were already giving him double dose infliximab. And at that stage, upadacitinib, which is probably one of the newest CABs on the rank for us, wasn't available, but a lot of us were able to access the drug through the patient familiarization program, which allowed early access. And luckily for this man, we were able to access it with an amazing response, actually. And we see that with upadacitinib, they respond really quickly. The trade name for that drug is Rinvoq, so a lot of you may have heard of it. And you initially started at 45 milligrams daily, and then you can choose a maintenance dose of 30 or 15. And with this guy, there was no question what I was going to do because he'd been so severe in the past. It's now on the PBS, but it wasn't at the time he started it. And this gives you some idea of his personality. And if you're his GP, you'll recognize the graph straight away. He kept in a tabulated form all of his symptoms. So the blue spikes are the frequency of motions in a 24-hour period. And most importantly, the red areas are the presence of blood and how many times blood was present in the motion. This was his first admission, and you can see the dramatic response initially in hospital, and then the relapse on prednisone weaning. And I didn't persist, even though he responded so well to infliximab, the way he was relapsing on prednisone wean, I just felt he wasn't going to respond. And look at this. This is around, I don't know if you can see my arrow, but there's that first big peak of illness. Then you can see that dramatic response. And then the second peak is when he failed infliximab. And then ever since upadacitinib was started, he's been kind of flatlining in terms of blood. Yeah, there's hardly any blood in the stool and the motions have reduced. That's really the case. Actually, I'm happy to take, and we're running well for time. So if you want to ask questions, you can in the Q&A. And in the interest of time, so I'll leave that time for questions. I'm going to keep going. But Martina, I'm happy for you to interrupt if there's a pertinent question. So fecal calpro became available on the MBS about 2 years ago, and it's an incredibly useful tool for you guys. And I want all of you to make sure you know this exists. So for a young patient, not this guy, but for a young patient who you don't know whether they've got IBS or IBD, it's fantastic. Under 50 years of age, long-standing gut symptoms. If you're trying to work out who to refer for further investigations, it's a fantastic test. And be careful, 50 is the cutoff labs use. Most of us use 100. So it's above 100, they should see a gastroenterologist, and because of the potential of IBD. If it's below 100, very happy for you guys to manage this as irritable bowel syndrome. Just very quickly, and again, very GP-centric kind of information away from IBD, but IBS is by far and away the commonest presentation to us. So I just wanted you to have a sense of this. It's very common, and the red flags that point, so it's often associated with anxiety, a degree of somatization of symptoms, and often a degree of health anxiety around symptoms. What the point of this slide is really for you to know what makes someone not likely to have IBS and more likely to have IBD. And that's the presence of rectal bleeding, weight loss, symptoms overnight. So they're passing diarrhea overnight, waking them from sleep, and older age of onset of symptoms. IBS doesn't usually suddenly come on when you're 60. It's usually something you've lived with all your life. And then, as I've said, blood tests are useful, and perhaps the most important, fecal calpro. So general principles of IBD management. So first, education and reassurance. It's a chronic disease. It's a lifelong disease. So the more you do upfront and the more effort you put in at the start, I think the better outcomes patients will achieve. That's both for us and also from you. And often you've already had a relationship with them and you're in the best place to provide education and reassurance around IBD. The second point I wanted to make is around goals of care. I think patients and GPs understand symptom management and symptom control really, really well in IBD and the need to manage symptoms. But we have two kind of phases of or aspects of goals of care. So there's symptom control and quality of life. But because it's a chronic disease, which can lead to chronic disabling complications, the second aspect is actually about preventing those complications. And the reason I'm making a point of this is sometimes people can have an excellent symptomatic response. They can be outstandingly well, feel great, back to normal, back to work, back to school, back at uni. But underneath the surface, if the disease is continuing, then they're still at risk of the more devastating complications. And I think we're a little bit behind the rheumatologists in this space. They've been very good at proactively managing diseases like rheumatoid arthritis to prevent future complications and disability, whereas we've been kind of for decades managing symptoms and not really until the last 20 years aiming for mucosal healing and trying to prevent complications. The reason that's important is when patients feel well and they're taking medications that have helped them feel well, and now they feel well, they often feel like they're cured and don't have a sense of a chronic disease. So often will stop their medications, which kind of segues into my next point is medication adherence. One of the first things I tell our registrars is less than 50%, I reckon even less than that, significantly less than that, of patients will be taking their medications as prescribed. That's normal human nature. Everyone's busy. We all have things going on, and no one is ever going to be 100% adherent. But I think if we can reach at least 80 to 90% adherence, we're winning. But a lot of the time, some of these patients don't even reach 50, probably 40% adherence. And I think that's not due to the patient or their personality. Often it's a lack of education, lack of understanding about the disease and its complications, lack of engagement with healthcare, lack of trust, all of the things that we can fix, both you and us, as their healthcare professionals. Then vaccinations and pre-immunosuppression screening, I'm going to talk about in a minute properly, but that is a critical part of IBD management. In case I do not have a slide on that. Yes, I do. Good. We'll come back to that. The other thing is proactive rather than reactive management. So rather than react to symptoms, if they attend monitoring, if they attend follow-up appointments and we're watching their calprotectin and blood tests, we can often predict an impending flare and make changes to their management before symptoms. So again, that encouraging attendance and follow-up is important. And then with medications, a lot of these medications, because they're long-term meds, they do have side effects and they do have risk. So really important to continue monitoring efficacy, adherence, and side effects. And then the last part of IBD management is screening for complications, most importantly, colorectal cancer. So uncontrolled IBD significantly increases the risk of bowel cancer. So adherence, I've touched on this, but I think you guys as GPs can make an enormous difference. And again, I encourage all our registrars to do motivational interviewing course, actually. And I don't know if any of you have done motivational interviewing, but I think we can make an enormous difference if we spend some time on it. And I think this is one of the most important aspects of IBD management, trying to make sure patients understand why they're taking the drug, giving them a sense of shared responsibility. It's not our responsibility to make sure they're healthy. It's a shared responsibility between both parties, or all three parties if you include the specialist as well. Trust and rapport is important. And this is particularly important because a lot of the drugs we use have side effects. So I like to warn people, like, for example, azathioprine, 20% of people will get nausea, arthralgias, they'll feel off, they'll feel really sometimes foggy in the head, sometimes just not quite right. So if you warn patients that this might happen, and often it's worse in the first 4 weeks, and if they ride through it, it often gets better. You don't want them to ride through a full-blown allergic reaction to azathioprine. That you want to know about, and I say that up front. If you get a rash or shortness of breath or severe abdominal pain, I want to know about it. And I also want to know about arthralgias and nauseas, but I warn them initially. And again, there are many barriers to adherence. You are all better at this than us, I think. I genuinely think that. So I don't need you to teach you how to suck eggs, but lack of knowledge about disease and why we're treating them. It's not just for symptoms, but also for prevention of complications. Some fear, and often fear kind of imposed on them by other family members. And that there can be lots of reasons why people have fears. It can be past experience. It can be someone having this drug and getting one rare complication, then the relative tells the patient about. All of these things kind of have an impact, and it's up to us to kind of discuss those in a compassionate and understanding way without dismissing. One of the key, again, I say to our registrars all the time, do not dismiss any concern, no matter how trivial, because you erode trust as soon as you become dismissive in your tone. And I think that's important. And I think understanding that everyone's human and not everyone's going to be adherent 100% of the time. And then sometimes people just forget, and I've got lots of little strategies for that. And again, you guys will be good at this. There's iPhone apps now, putting it next to something they do every day, like brushing their teeth. Lots and lots of things we can give them. And again, I suspect you probably can teach me more about adherence tips than I can teach you. Screening and vaccinations, an important part of IBD management. I like to do this at the very start, and some of you would have seen my letters asking if you would mind vaccinating patients against some of the preventable things before I put them on immunosuppression, or even after I've put them on immunosuppression if it's not a live vaccine. So sun protection is really important. We are living in the skin cancer capital of the world, and then we are using a drug which increases the risk of skin cancer. So we really need to be very, very proactive with skin, both prevention and after 5 years of azathioprine, definitely after 10 years of azathioprine, I get regular skin reviews with either a good GP who's comfortable in skin review or a dermatologist. As part of our screening at the start, we check for any diseases or infections which may affect future immunosuppression. With Mesavant, there's no issue, right? It's only the other drugs. So with mesalazine, sorry, I shouldn't say Mesavant, with mesalazine, whether it be Pentasa, Selafolk, or Mesavant, it's not immunosuppressive, and you can give whatever vaccines you want, and there's no problem. But some of these infections may prevent use of some medications or may need us to be cautious about the use of some medications. So very quickly, live vaccines can't be given once someone's on immunosuppression. And if they're already on immunosuppression and you want to give a live vaccine, you've pretty much got to wait 3 months off immunosuppression before you can give a live vaccine. If you want to give a live, if they're well enough, if it's not like the guy we presented, but a case of mild colitis who responds really well to mesalazine alone, then you've got a window to give all the live vaccines you want before they might need Imuran, azathioprine, methotrexate, or one of the other drugs. So this is the perfect window to give some of the live vaccines. So measles can wane over time, and measles is one that I always check, and it's still around, unfortunately. So if there's a window to give the MMR vaccine, I will. The old varicella vaccine was live, and again, if there was a window to give it, we would. Shingrix, which is now available, as most of you know, the government has limited that to essentially people with either hematological or solid organ transplants. So our IBD patients, unfortunately, do not have enough immunosuppression to qualify for Shingrix on PBS. But most patients are happy to, a lot of patients are happy to pay for it because it'll protect them. And particularly if they're on immunosuppression already, it's your only choice, all right? Yellow fever, young people like to travel, and I always ask them in the first 2 appointments, do you have any kind of plans in the next decade to travel, or do you want to travel, or are you interested in travel? And a lot of patients don't know, but the benefit of the yellow fever vaccine is that it's robust. So you give it once, and then they're protected pretty much forever. And the reason that's important is, as most of you know, you can't travel to some of the yellow fever endemic countries without the vaccine. The government won't let you. The questionnaire has yellow fever in it, and you can't come back in to the country without vaccination or an exemption letter from us saying this person can't have the yellow fever vaccine. And then they take their own risk traveling to those countries where yellow fever is endemic, and the disease can be fatal. My view around that, there's a vaccine, it's live, and if you get a window to vaccinate young people, I encourage them to take it. You obviously can't force anyone to do what they don't want to do, but I encourage them to have it while they're young. Then there's all the inactive vaccines. You can give them when they're immunosuppressed. They may not have the perfect response, but actually one of the things the COVID data showed us is that the immune response is perhaps not as blunted on immunosuppressive therapy as we thought. So hopefully everyone understands me there. Inactive vaccines are safe, but they may not launch an enough or adequate antibody response to offer protection in immunosuppressed people, but probably enough. All right, fertility and pregnancy, really important topic. And really important in the management of IBD of young women and men. So in young women, I usually bring up fertility and pregnancy in the 3rd or 4th appointment with me. I generally don't think it's a good idea to bring it up in the first appointment unless the patient brings it up. The reason this is important is there's so much misinformation, so much. And unfortunately, amongst patients, and healthcare professionals, medical, nursing, allied health. The things that are important to understand is disease control is probably the most important thing in terms of falling pregnant, so successful pregnancy or successful conception, sorry. And actually, disease control is perhaps the most important determinant of pregnancy outcomes. And that's really, really important to highlight. The other thing that's underappreciated is the background rate of congenital abnormalities. So you probably all know this, but the background rate of kind of fetal abnormalities in the normal, healthy, well population is around 3%, which is higher than you'd think, but the data says 3%. And a lot of the drugs I'm going to talk about, it's 3% or less. And we'll talk a little bit more in a second. The other thing about pregnancy is that because of the relative immune suppressed or immune tolerant state, patients often feel this period of honeymoon disease control where they feel better and they feel well controlled. And then the third point is it's poor disease control that unequivocally increases the risk of bad outcomes. And I think once patients understand that, the discussion around drugs, which is a very emotive issue and understandably anxiety-provoking issue amongst patients and us, is a lot easier to discuss. And like a lot of chronic diseases, it's very much about the risk of the disease versus the risk of the drug. I just want to caution you against using MIMS alone. Unfortunately for all of us, MIMS is like a readily available source of data. But most of you may not be aware, or some of you may not be aware, that the MIMS data or the MIMS category of a drug in pregnancy is related to its FDA class. And the FDA class in America has to be based on pre-registration data of a drug, i.e., before the drug came on the market. So all the wealth of post-registration data since the drug's been on the market, for example, with Imuran, all of the decades of experience in all of the pregnancy studies that have been done on Imuran can't be used in the MIMS pregnancy class. So azathioprine is the best example of this. Unfortunately, it's given a class D on MIMS when all of the data around pregnancy in decades of literature, and thankfully now some fantastic society guidelines, both from ECHO in Europe, the American Society, and now the Australian IBD Association as well, a table of safety of drugs in pregnancy, which is not the MIMS class, but actually based on data. And azathioprine falls into the safe category. And that's really, really important to understand. MotherSafe are fantastic in this space. And some of the Prince of Wales pregnancy physicians and St. George pregnancy physicians are fantastic in this space as well. Most obstetricians are fantastic, but I've had Imuran stopped multiple times in my career by an obstetrician or GP. And then the patient's flared. And that's the thing that it relates to bad outcomes, not azathioprine. Just to show you how inaccurate MIMS classes can be, infliximab is given a class B. However, we know that it's a monoclonal antibody and actually hangs around in the newborn. What do we know about placental transfer of IgG antibodies in the third trimester? Antibodies cross the placenta multifold in third pregnancy to protect the baby from infections. But what's infliximab? It's an IgG antibody, isn't it? So the baby is born with more than 10 times the level of infliximab in their bloodstream than mum, which is why the guidelines very clearly say if mum had infliximab in pregnancy, the newborn absolutely should not get any live vaccines. Now, thankfully, in our blue book, the only way, the first live vaccine, as you know, is actually the MMR at 12 months, except the rotavirus. So please don't give any newborn of a mum with infliximab the rotavirus vaccine. That's the only one they really miss out on. So that's an important point, and we'll come back to that in question time. So in the last 10 minutes, I'm going to take you through a Cook's tour of the IBD medications, and we may not have time for the cases as such, but again, depending on how we're going, happy to do a couple more cases.
There's no questions so far, Gok.
Okay, good. So IBD medications. I'm actually going to skip over corticosteroids, except to maybe highlight these two at the bottom here. So Entocort, because you know this well already, Entocort is budesonide, which has less systemic absorption. For someone like our guy, budesonide is a great option because of his problems with anxiety, depression, and how prednisone exacerbates it. Unfortunately, not everyone responds as well to budesonide, but it's a really good option if you're trying to minimize the short-term and long-term side effects of budesonide, of steroids. So Entocort is the small bowel release version, and it's now on the PBS for Crohn's. So thankfully, patients, like 3 years ago, it was $200 a month, but now it's on PBS. Cortimin, which is what you'd use in ulcerative colitis because it's colonic release. No point giving Entocort in ulcerative colitis. So colonic release Cortimin is still not on PBS. So that's about $200 a month for patients. Entocort comes in 3 milligram tablets, Cortimin in 9. I'm not going to bore you with steroid side effects, nor am I going to bore you with mesalazine. I might just quickly mention that we now have metabolite testing for this drug, as we talked about, and those are the rough levels. And we've talked about this already. And as I said, I want to focus on the new drugs, but pancreatitis, a really bad complication. So I always warn patients, if you get severe abdominal pain, I need to know. So if you've got someone recently started azathioprine, severe abdominal pain, stop the drug, ring us. The other thing that can happen with azathioprine is the nasty Stevens-Johnson's type reaction. Again, stop the drug, ring us, not to be re-challenged. Abnormal LFTs, sometimes you can get away with dose titration, but we'll talk about that later in question time if you want to. Again, methotrexate, I avoid in young women. I try and avoid it because even if you talk about dual contraception, so we talked about drugs that are safe in pregnancy, right? This is one drug that is absolutely not safe. And this and mycophenolate are the two drugs I would very much caution, and all of the societies have put in that unsafe category for IBD. So again, I try not to use it, but sometimes we do have to use it, and I spend a lot of time talking about contraception. I won't talk too much about the indication, except to give you a flavour that there's a 6-page application form we fill in to apply for these drugs, and generally patients need to have failed at least 3 months of mesalazine plus azathioprine or an equivalent like mercaptopurine or methotrexate. Anti-TNFs, the oldest of the options available to us. Fantastic drug still, work really, really well. Infliximab used to be only in infusion form through the drip, but now available in subcutaneous form, which a lot of patients prefer subcutaneous versus IV infusion, as you can understand. But a lot of patients are happy to bring their laptop, sit in an infusion center, and receive infusions. The one thing I wanted to highlight in this space is around the world, there's very good data that patients need more than 5 milligrams per kilogram of infliximab, or the standard PBS doses essentially, but the government will only pay for standard PBS dosing. I'd say 50% of our IBD clinic patients are on escalated dosing, and it's a little bit unfair because we tend to attract the more severe, and same with my private practice, it attracts the more severe patients, and hence, of course, they're going to be sicker and potentially need more medication. And we have to fill in an application form, and thankfully the pharma, to their credit, despite all their shortcomings and downsides, have been fantastic in this space in supplying free medications to multiple patients so they can have the right dose of drug. Because we can now measure trough levels with these, which you may not have been aware of. And if the trough level is low, we can push the drug up either by reducing the frequency of dosing from 8 weekly to 4 weekly, or as most of my patients say, no, I do not want to come in every 4 weeks. We increase it to 10 milligrams per kilogram, double dose every 8 weeks, and both achieving the same outcome of more drug. Same with Humira. You can increase the dose with compassionate access. Vedolizumab is very, very attractive because of its gut specificity. It doesn't suppress the rest of the immune system like the other medications and works very much on the gut alone. So of course there's an increased risk of gastroenteritis, increased risk of nasopharyngitis, but actually significantly less in systemic infection risk. And I mentioned the COVID data before. When they looked at the antibody titers to the COVID vaccine, patients on Vido had almost normal antibody response to the vaccine compared with patients on infliximab or Humira or one of the other more systemic immunosuppressive drugs. So a great option in older patients who you're worried about infection, or someone who's had bad infection recently, or even in the kind of malignancy space, a lot better in terms of preventing or worrying about immunosuppressing the patient. It is a sister drug of natalizumab, but no reported cases of PML with Vido. And as I said, a great drug for the elderly or comorbid patient. Stelara is an injection you give every 8 weeks. Again, a very good safety profile so far, even though it's systemically immunosuppressive. It's a subcutaneous injection. So the first dose is IV, and then it's a dose every 8 weeks. It blocks IL-12 and 23. Some side effects, but again, safer. Very good medication. Some of the benefit of this drug over the anti-TNF, the anti-TNF drugs need an immunomodulator with them, because often if you give an anti-TNF drug by itself, patients form antibodies to that drug and they get this thing called secondary loss of response, where the immune system and now antibodies we produce kind of mop up the anti-TNF agent before any efficacy. So we generally don't use the anti-TNFs as monotherapy initially, in the initial period, whereas the data around antibody formation to Vido or ustekinumab is less, and it's less of an issue. I mentioned these drugs at the start, but UPA is a fantastic tablet drug. It's a selective JAK1 inhibitor, and it's a tablet. So it has the big advantage of not having to come into hospital for an infusion or not having to inject yourself. It's a once daily medication, and it really has changed the landscape of IBD management. It came onto the PBS for ulcerative colitis in 2023 and came onto the PBS for Crohn's a couple of months ago. So a fantastic drug for IBD. Big issues: significantly increased herpes zoster infection. So I pretty much mandate Shingrix vaccine before I give upadacitinib, and they're usually already immunosuppressed. That's why I'm mentioning Shingrix. If they're not immunosuppressed and you want to use UPA, then you could give the old vaccine, but you have to wait 3 weeks before you can use the drug, because that's a live vaccine, all right? But even if they've had the zoster vaccine, even if they've had chickenpox, I still give Shingrix to prevent zoster. The other thing about UPA is that in the rheumatoid arthritis data, there's been an increased risk of cardiovascular events. So there is a kind of black box warning around this, even in IBD, even though in the IBD patient population, that has been less of an issue. And perhaps the IBD patient population is a lot younger than the rheumatoid arthritis. So the mean age of the patients in those trials that are talked about in the rheumatoid arthritis space was well over 50. And most of our patients are under 50. Lastly, ozanimod. It's a selective S1P receptor modulator. So essentially what it does is it stops lymphocytes getting out of lymph nodes, kind of leaving lymph nodes. So they can't get to sites of inflammation. At the moment, it's only on the PBS for UC. Again, I'm very particular about zoster vaccination first. It does cause lymphopenia, and you need to watch that very carefully. And it does cause bradycardia. Always get an ECG first. And there's a way to introduce the drug to try and reduce the risk of bradycardia or arrhythmia. So always ECG before starting the drug. Raised LFT sometimes and macular edema. So that's really all I wanted to say. I've got 2 cases that we can talk about if you felt like it, but I also wanted to give time for questions. So take-home messages, recognize the red flags. Fecal calprotectin is incredibly useful. The diagnosis of IBD needs history, blood test, endoscopy, and histology, and you know that. And where all of you can make enormous difference is in screening and vaccinations, which we will organise, but we need you to follow up and likely give vaccinations if possible and if appropriate. Please try not to stop critical medications in patients who need them, or at least talk to us, pick up the phone and ring. I know, and just be aware of the pitfalls of using MIMS alone. MotherSafe is a fantastic resource, and I'm sure a lot of you have used it. And hopefully you've got an understanding of the multiple new medications available. So Martina, I thought I could take questions, and then if we wanted, I've got 2 other cases, but again, up to the group, to be honest.
Great. I've got 1 question at the moment, so I'd invite other participants to add any questions, but I just want to say thank you very much for a very wide-ranging and detailed summary. The first question is, what is TPMT level?
Yeah, so TPMT is the enzyme that breaks down azathioprine. And as part of that pre-immunosuppression screening where we test for varicella, Hep B, Hep C, EBV, CMV, quantiferon gold, we always do that because 1 in 100 people are profoundly TPMT deficient. And if you give them a normal dose of azathioprine, they are guaranteed to get leukopenia, and they're guaranteed to have a non-existent white cell count as soon as you give them Imuran. So it's now part of the screening. So the people who are truly TPMT deficient, I use a much, much lower dose of Imuran or don't use Imuran at all. And there's a group that are kind of midway, like that aren't super, super low, but low. And again, similar principle in that. And actually, we used to do level. Now the cheaper test, as it turns out, is TPMT genotype. But it gives you the same answer. It says normal genotype equals normal azathioprine metabolism, same with 6MP. And then there's the intermediate metabolizer, who you need to use less dose. And then there's the one that's absent, where you cannot use Imuran or 6-mercaptopurine. Do they need, I've got the Q&A up as well.
You can see them. Yeah. Do they need quantiferon gold TB test, especially in migrants?
Yeah, pretty, even non-migrants, Asha, I do quantiferon gold. Everyone should get a quantiferon gold. So we have a pre-formed blood sheet ready to go in IBD clinic. And in my rooms, I have a button that I click on the software that does the pre-immunosuppression screen, which includes quantiferon gold. I think it's really, really important in all patients, not just migrants.
And nudge, nudge, I hope you've got a copy to GP of those pathology forms, because that's really helpful for us.
Yeah, no, always, Martina. Again, thankfully in the rooms, that's automatic, actually. So it just automatically CCs you guys. Because there's no point me asking you to vaccinate people when you don't have the serology.
Exactly. And also, you know, patients move around, so it's helpful for the GP to be able to look back and see. Okay, the next question is, do you use the same medications and doses in over 50-year-olds?
Yeah, so worry about azathioprine in patients, particularly over 60. 50 depends on what they're like. Out of all of the drugs, prednisone is actually the worst in terms of infection risk. So in a way, we're trying to, with all these other drugs, we're trying to prevent overuse of prednisone, aren't we? So in all of the studies, the one drug that's associated with the highest infection risk is prednisone. But I worry about things like skin cancer and lymphoma in Australia, and I try not to use Imuran in people over 60. The problem with that is the government in the PBS, you pretty much have to use Imuran for 3 months before you can use some of the biologic drugs. So you want to get through those 3 months quickly and just get rid of the drug, to be honest, in that other patient. And then I have a tendency either to use vedolizumab in patients over 70, again, because of the safety profile, and again, because of the fact that it immunosuppresses the gut only. But actually, if you're going to use a drug, pretty much in the same doses. So if you've made a decision to use a drug, maybe with Imuran, maybe less, but with the other drugs, pretty much the same doses, because that's where the evidence for benefit exists. In trials of vedolizumab at lower doses, it just wasn't there, or the other biologics. So yeah.
Yeah. Thank you. There's another question that says, what happens to the old patient who developed ulcerative colitis who's after stopping smoking?
So yeah, excellent question, Eva. As all of you know, recently quit smokers and ex-smokers have a higher incidence of IBD. The older patient, there are two things about the older phenotype. So we always thought of IBD as a young patient's disease, but as you know, there's a second group, a second peak in the elderly around 60 to 70. That patient often has a less severe phenotype. So again, in answer to your question, you could argue you could get away with less immunosuppression. So even though I said the doses are the same, that's the patient I might just use Vedo 300 milligrams every 8 weeks without any other drug, without Imuran or anything like that. So very similar to the answer to the previous question, Eva, that it would be treating them the same way. I wouldn't encourage them to start smoking, but I would give them other medications like Vedo.
Sounds pretty sensible, doesn't it? All
The
right.
amount of patients that have asked me that, though, what if I just start smoking again? I'll feel
Yeah,
better. Yeah,
that's all
you're
right. You can die of lung cancer or heart disease instead. It's up to you. There's no more questions, Gok, and we've got 6 minutes to go. So have you got a short case?
Yeah, the cases are instructive. Let's do it.
Okay. Oh, one's just come in. Is it possible that gut dysbiosis could cause IBD? If scientists can isolate all these inflammatory molecules, how come they can't find microorganisms? I think the problem is that they can't find out the therapeutic interventions.
Yeah, I think we're getting better in this space, and a lot of our research at St. George with Emad El-Omar, who's the head of the Microbiome Research Centre, and we're lucky to have him at St. George. We're doing an enormous amount in this space, and you might have heard of the AIM study, which we're a part of at St. George, which really is trying to map the fecal microbiome of patients with IBD, and look at what happens during flares to that microbiome. And as Martina's alluded to, how do we kind of intervene in that setting where we're less good at? But I think we'll get there, and I think it is probably the future of IBD management. I do, but we're not there yet. So 63-year-old man, fit, married, fit, active, carpenter, still working, type 2 diabetes, hypertension, hypocholesterolemia. So your standard type of patient which you'll look after, right? So 6-week history, 5 to 6 days, blood and mucus, some pain, some weight loss. What do you think? I mean, I want you to maybe put in the Q&A. Further investigations. It's hard to
I'll
make
read them out as they come through.
And I've got it open too, Martina. So
okay.
I've worked out how to have it open on both on the screen.
Well, I can't type in, so I'm going to put infectious stool investigation
Yeah,
to make sure.
absolutely. So
Mm.
excellent. Infection first. Some of these blood tests, yes, history of travel, excellent. So I wanted to give you a flavor that sometimes albumin drops, sometimes CRP goes up, sometimes there's a thrombocytosis, but the calpro can be super useful. Now, I told you the lab uses 50. If the calpro comes back 630,
Oh.
that's a little bit more worrying. And our patient was 4,000, right? So you saw that. So this patient had UC, and again, one of the things we look for on biopsy with new patients is the presence of chronic change. So if you saw that on colonoscopy, it could still be infection, but this patient's had symptoms for 6 weeks, right? So most infections don't last 6 weeks. And then the presence of chronic changes on biopsy just clinches the diagnosis. And again, it was more a diagnostic type of case. And I really wanted to highlight the importance of history. So diarrhea more than 2 weeks or symptoms more than 2 weeks, the presence of weight loss and blood and mucus, that points you away from IBS. The importance of CRP, hemoglobin and albumin, and perhaps most importantly, calprotectin, and then the colonoscopy. And my
Who has
second,
known UC, Gok, and she presented with a history of diarrhea for about 3 weeks, and I thought it was a flare. But she had recent travel, so we did stool culture, and we got that bloody blastocystis.
Yeah.
And it threw us off, you know. So she then, because she really didn't want to go to hospital, she was like, let's treat that first, and it delayed her accessing up titration of her treatment of UC. So
yeah, look, that can sometimes happen, can't it? There's nothing stopping patients having both.
Yeah.
And sometimes it does delay it. But one of the things you don't want to do, particularly, for example, if it's C. diff, is titrate immunosuppression. And just, I guess, as you know, blastocystis, dientamoeba, it's that kind of murky space of some literature suggesting maybe it causes disease, but the majority of literature kind of saying probably not. But then patients, as soon as they look on the net, as you know, almost drive that process. Well, this is definitely the cause. I want treatment for it first, which you know is very reasonable, as all of you know. You guys are in that space a lot more than us. Yeah, probably no treatment, to be honest. If I see blastocystis, I leave it alone. It'll either go away or potentially not cause, potentially not the cause of their symptoms. And as Martina alluded to, it's that test where you kind of sigh because you know you're going to have to try and explain this to a patient.
Yeah.
And
Gok, I'm taking
that
advantage of this question to actually type in that most recent question a link to the health pathway on inflammatory bowel disease, because I can't put it in the chat for the participants. So anyone who wants to see, because we've got quite a lot of the things that you've covered for people to
yeah, that's an excellent point.
sprig their memory. Yeah.
Now,
I think we've come to the end. So,
do you want me to say anything about the SRC criteria quickly?
just one thing, and then I can't post a link to the, we have got also the SRCs listed on the non-acute gastroenterology assessment, but I'll let you say more.
I'll just answer this question very quickly too. Can Crohn's present? Yeah, absolutely. So the symptoms kind of relate to location of disease. So Crohn's colitis can present identically to ulcerative colitis. So look, around New South Wales, all of the outpatient clinics, and I've spoken to so many of you individually, and Martina, I've spoken to you as well during some of our grand rounds, are absolutely swamped. And as a result of that, the government has put in some criteria for referral to the general gastroenterology clinics at public hospitals. So they've got some very strict criteria which requires tertiary level care. And unfortunately, a lot of the things we have been seeing over the last few decades is probably going to change, and there's probably going to be a lot more. We do not have the capacity to see this kind of patient, and all of that is available. Martina, I don't know. I think it has been sent, or I know it has been sent to everyone, PHN and other areas, but distributing it to the GPs will clearly take time. And it only came into effect this month, team. So if you didn't hear about it, it's only because it's literally just started. Is that a fair comment, Martina?
Look, I just want to back that up and say on the health pathway for non-acute gastroenterology assessment, we have the first tranche of SRCs that released last year, and the inflammatory bowel disease and the bowel cancer ones are on that. And we're just in the process of updating with the second tranche. But the other thing to know is that if you're referring to a public hospital, outpatient clinic, not St George, but Sutherland and Prince of Wales have electronic health referrals now. So you can use your HealthLink in your clinical software and find the referral form for the specific condition, and those referral forms host the statewide referral criteria. And the important thing about that is you can identify roughly the kind of wait time your patient's going to be looking at in a standard referral, and also the required information that you need to send so that the team can triage. And that can be really helpful, because you don't want to get your referral back saying you didn't include this test and we're not going to allocate an appointment until you give us the result. So we've tried to make it easy by making the requirements for referral visible on the health pathway, and also in the HealthLink referrals for the services that receive them. Hopefully St George will upgrade soon.
Sorry, I tell you, a little bit behind, if I can say it in a politically correct way.
Well, it's not your fault. It's up to the people with the money to allocate it to doing it, isn't it? So,
yeah. And that's a statewide thing, team. That's
yes.
The SRC, it's statewide referral criteria, essentially kind of listing the things that need tertiary level care at a public hospital. For example, with anemia, it's iron deficiency anemia, not anemia. It's just a one-off example.
Just wanted to say thank you very much, Dr. Paven, Dr. Gleeson and Kylie for the session this evening. There's lots of really practical applications of the information that you've been able to share this evening. So very much appreciate your time